Your A1c number can feel like a final grade on your health. It is not. It is a delayed report of your blood sugar pattern, not a snapshot of today or a verdict on last night. A lower number is usually better, but the safest interpretation asks what created it. The number can hide spikes, lows, and medical factors that one average cannot show clearly. Many people see one A1c result and think it explains everything. That reaction makes sense because lab reports often look exact. The problem is that 1% can make real life look cleaner than it is. Your body does not live as a single percentage every day. The better question is simple: what pattern produced this number? A result can reflect steady readings, sharp spikes, hidden lows, or medical factors. That question turns A1c from judgment into information. It also changes the next step from panic to pattern checking. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. The A1c test is a blood test that estimates average blood sugar over recent months. Blood sugar means glucose, the main sugar circulating in your blood. The test does not require fasting. It gives a broader view than one fingerstick reading after one meal. Here is how it works. Hemoglobin is the oxygen-carrying protein inside red blood cells. Glucose slowly sticks to hemoglobin as those cells circulate. More glucose exposure leaves more sugar-coated hemoglobin. The lab reports that coated portion as a percentage. Red blood cells live for roughly 3 months, but the test is not a perfect calendar. Newer cells contribute more to the final result than older cells. That means recent weeks often influence your A1c more than a meal from months ago. That timing changes how you should react to one result. Stress, steroid pills, illness, sleep loss, or major diet changes can move the number. One result is a clue, but it needs context before it becomes a decision. The usual ranges are simple. Below 5.7% is considered normal. From 5.7 to 6.4% is considered prediabetes. A result of 6.5% or higher can be in the diabetes range. These ranges help doctors act before damage becomes obvious. Those cutoffs are not magic walls. Moving from 5.6 to 5.7 does not mean your body changed overnight. It means your measured risk crossed a line that helps doctors act earlier. The line guides decisions, but the full pattern gives context. Diagnosis also should not rest on guesswork. A doctor usually confirms abnormal results, especially when symptoms are not obvious. A fasting blood sugar test may help. A blood sugar test during symptoms may help. An oral glucose tolerance test checks blood sugar after a measured sugar drink. Once the result is confirmed, the next question changes. Prediabetes usually means risk reduction before diabetes develops. Diabetes means diagnosis, safety, and a treatment plan with your doctor. The category matters because it decides what action comes next. A useful translation is estimated average glucose. That means the average blood sugar number that roughly matches your result. For example, a result near 7% often matches about 154 on a standard American glucose meter, but one average can mislead. The same percentage can come from calm readings or sharp swings. That number may look neat, yet it still cannot show timing or after-meal spikes. It also cannot show whether the pattern is improving or worsening. It also cannot show medication-related lows. This matters most for people already using diabetes medicines. A lower A1c can look impressive while hiding frequent low blood sugar. Low blood sugar means glucose drops too far for the brain and body to function safely. It can cause sweating, shakiness, confusion, or fainting. So the goal is not to worship the smallest number. The goal is a safer pattern. For many non-pregnant adults with diabetes, a common target is around 7%. That target is not automatic. The same target can be right for one person and risky for another. Age, pregnancy, kidney disease, heart disease, and low blood sugar risk can change the goal. A practical approach starts with comparison. Look at your previous result, your current result, and your usual readings. Direction over several rounds of testing often matters as much as the single number. That keeps one lab result from becoming either denial or panic. Small changes also need perspective. Dropping from 9.2 to 8.4 may still be above goal, but it can show progress. Rising from 6.4 to 7.1 may not feel dramatic, yet it may reveal a slipping pattern. Some situations make A1c less reliable. Anemia means low red blood cells or low hemoglobin. Kidney disease, blood loss, and transfusion can distort it. Pregnancy and inherited blood traits can distort it too. The practical question is whether the number fits. Symptoms, home readings, and medical context should line up together well. A number that does not fit the rest of the story should not be ignored. It means the result needs a second look. That is why the office conversation should be specific. Bring your medications and home readings. Bring recent weight change, symptoms, and any low episodes. Mention problems with your meter or sensor. Explain recent illness, steroid use, major diet change, or unusual stress. Home glucose readings can add practical detail. Fasting readings show the overnight baseline. Post-meal readings show how food, timing, and movement affect spikes. Continuous glucose monitoring, often called CGM, uses a sensor to estimate sugar patterns throughout the day. Morning readings can point to a different problem than evening spikes. The dawn phenomenon means an early morning rise in blood sugar from overnight hormones. Late snacks, alcohol, sleep apnea, and missed medicine can also shape the morning number. That detail changes the conversation. Once those patterns are visible, the number becomes useful when it changes behavior. Ask what pushed it up, not only how to push it down. Liquid sugar can move the average. So can large refined carbohydrate meals, late night snacks, poor sleep, missed medicine, and inactivity. Then separate the next step in plain language. You may need a confirmed diagnosis, a treatment change, or better daily data. That choice depends on the problem. The issue may be uncertainty, unsafe highs or lows, or an unclear pattern. The next step should match the real problem. If your A1c is already treated, ask a different question. Are you reaching the goal without frequent lows? High readings may cluster after breakfast, dinner, or late snacks. Pattern beats blame because pattern tells you where the next change belongs. Do not chase A1c with extreme dieting or skipped meals. Those tactics can create lows, hunger, and rebound eating. A safer plan usually targets repeatable habits and the main glucose sources. The best change is one you can keep doing. Retesting should connect to a decision. Many people check A1c about every 3 months after treatment changes or unmet goals. Others may check less often when stable. The point is not repeating the number for its own sake. The point is seeing whether the plan is working. Your A1c is not your character, your effort, or your future. It is a scoreboard, not a biography. Use it to spot direction, confirm risk, choose the next step, and check confusing results against the rest of the story. One number matters most when it leads to a safer pattern. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.